Please, Dr. Shreya.
Thank you so much, Dr. Rohit, for a nice word. I'm thankful to the people allowing me to speak on non-surgical management. When we understand non-surgical management, it doesn't understand only strabismus. It has to be understood diplopia, confusion, strabismus, and nystagmus. So our talk will go on 4Ws: which, what, where, and when. So we must understand which kind of the strabismus it is and at the what stage the strabismus it is. According to that only we can treat ranging from asthenotic symptom to the manifestropia. And we have long list of strabismus workup which is already discussed by previous speakers, including fusional amplitude and reserve and accommodation amplitude also. Let's see when, where, when to intervene, where to intervene, and what to do to intervene. For that, we must have option what are the available to intervene. Refractive correction, bifocal over minus monovision is the choice of treatment. Second, orthoptic exercise vision therapy. For convergence insufficiency, fusional training, anti-suppressant training, smagnocellular stimulation, prisms also incorporation in glasses or Fresnel prism. Occlusion and fogging can work. Medical therapy can be miotics or cycloplegics, pilocarpine and cholinesterase inhibitors nowadays not used because of the side effects. We may use levodopa, carbidopa for treatment of amblyopia. Injections, Botox and bupivacaine, yes. And there are other options: acupuncture, meditation nowadays, education assistance, surgical correction, and the combination of treatment. So now let's see when and where to know where the problem lies. So if the patient has diplopia confusion, the first thing is similar images on the on non-corresponding points. So if you look the isotropic eye, the person gets two images. One is already through fovea and one is from the isotropic eye. So in this kind of patient, we'll have diplopia present only under the binocular condition. Confusion worse viewing the bright stimulus in a dim light. The second option for under this condition is retinal maculopathy. So here the eye may be aligned, but the cells are misaligned. So if you look carefully, if the light focus on this, it will go normal vision. In this kind of patient, diplopia almost always have vertical or diagonal, and it worst in bright line. So when light falls on the deviated cells, then the confusion starts occurring. So we must understand what is the cause. The second possibility of unfocused light projecting on the second image. So their first option is higher order higher error aberrations. So in this condition, if you put the cover test, if diplopia will not go, but if you put pinhole, the diplopia can be corrected. That is because of irregular astigmatism. The second cause in unfocused light is dry eyes. And again, the same thing will be there because of irregular anterior optical interface. The third possibility can be inability to fuse the images on corresponding points. So this is a very small group of people. The problem lies in the visual pathway, and this kind of patient will, if you ask where is the second image, they will not be able to tell because most of the time it will be floating image. And in this also, second is the problem may lie at the cortical level, paradoxical diplopia. Again, there can be a anomalous binocular correspondence. So we one by one see what to do. If there is a similar strabismus neuromuscular defect, refractive correction will definitely work. Horizontal strabismus correction can be done, and don't forget to add the accommodative components or over minus whatever we want to do. Orthoptic exercise, yes, it even in large angle of strabismus with some fusional control, mainly in intermittent, and there should no limitation on the ocular rotations. In prism in glasses, if small to moderate angle tropia, capable of sensory fusion and fairly commitant division. But if it is non-commitant, we can use Fresnel prism. And occlusion fogging, we'll keep if the fusion is not able to achieve. Let's go to the second option. When there is a retinal maculopathy, refractive correction can be done best if no metamorphopsia is there. But then it is to be detected by Amsler grid or spectrum domain OCT. And good spatial localization is there. We can correct with the refractive correction. Maximize the acuity, monovision with the dominant eye for distant and non-dominant for near. Orthoptic exercise will not work here. Prism. give less amount of prism, because most of the people will ask more and more and more, they adapt to it. So try to avoid prism. Fogging and occlusion if other things are not possible. If you look into higher order, again the refractive correction by bifocal, but here always switch from the spectacle to contact lens or refractive surgeries. Prism and orthoptic shears are not possible, and again the fogging when needed. Dry eyes, treat the cause. If you look at the visual pathway problem, then isoconic lenses for anisoconia spectacle can be prescribed. Orthoptic will not work here. Prism again may be helpful, but that second image we need to put on the scotoma, so patient may increase strabismus or create one if it is not there. So occlusion also Bengerder's filter and adhesive tap can use. And if it is cortical, optical correction will not work. Orthoptic exercise can relearn the suppression. Prisms contraindicated, and fogging can be done with the. So when we do orthoptic exercise with some certain aim, and we have criteria to start the orthoptic exercise, because it has got the greatest risk of developing intractable diplopia. So we'll just move on, or we'll not discuss about the orthoptic exercise. That are many available, but we have done. Am I audible?
Yes, doctor, you're audible.
Yeah, I'm not.
I also request you to please come to the.
Yeah, I'll just sum up and I'll just ending.
Thank you so much, doctor.
1 second, I'll just go through. So I just wanted to tell about this magnocellular stimulation. So that is what we have done in few patients recently for 6-7 patients, and we have seen some improvement in vision, but not much of in a strabismus. Still, our prospective study is going on. Botox and bupivacaine is always an option for the treatment. Be aware when you are using bupivacaine because of its side effect and mode of action. It can create orbital inflammation, but it has to be injected with EMG guidance. So sometimes we may have to give postoperative strabismus, and other options are not the scope of this talk. Nystagmus workup can be done properly, and these are the algorithm to use in nystagmus surgeries. Thanks to my patients, thanks to my teachers, thank you.